so excited for this, mostly because Leah has become a very good friend of mine, and this is my pre-birth lactation consultant appointment. And I'm so excited to share it with you. I'm just gonna unenable the waiting room, change my name so people know who we are, and we will get into it. And even though this is designed to be for me, we want to answer your questions, so feel free to drop them into the Q&A and we'll do our best to make sure everyone gets heard. And on that note, Leah, do you want to introduce yourself?
Yes, I'd love to. My name is Leah Tibus. I'm a registered nurse and an international board certified lactation consultant. I've been working with moms and babies for a little over 22 years now. I love lactation consultations. I love prenatal consultations the best. And this is my quick plug for anytime in your last trimester, make an appointment, meet with a lactation consultant, whether you've had a baby, whether you've had 3 babies, it's your first baby. You can learn so much and be so much more ready for what comes next. I would say about 90% of all the consults that I get that are postpartum are for issues that probably could have been prevented if I was already working with a family. So I think just knowing that piece of it, your chance of meeting your goals is so much higher when you meet with someone in that prenatal period. So I love these types of consults.
Awesome. All right. Well, for context, everybody, I am due 1 month from today, and I was telling Leah, like, it would be very good content if my water broke on this call, but we want a few
I
more.
told her not yet. She needs a couple more weeks to bake.
Not yet, yeah. And Leah's kind of just gonna run the show. I don't know what to expect from this, but I'm excited to dive in. I told her nothing is off limits, so
Yeah.
I'm here for it.
All right, great. So what we do is we like to start with just kind of finding out what any health history that's relevant to lactation for you. So first I'm going to ask if when you got pregnant, did you notice any changes to your breast? So breast tenderness, like additional veins popping up, size change, anything like that?
I mean, size change. So naturally, I'm like a double D. My boobs, I found a bra that I ordered, I guess, last pregnancy. I was like, is this a parachute? Like, my boobs changed in size a lot the first time. My nipples got really dark.
Yep.
Um, and like the little bumps on my nipples, I
Yes.
felt like had milk in them in a weird way.
No, that can happen. So the Montgomery glands, if anyone that's off camera wants to look at their breasts, your Montgomery glands look almost like little tiny whiteheads or pimples around your areola. And
Yeah.
they excrete this fantastic oil. They condition the nipples, and they're great, but don't pick them. Don't
Okay.
mess with them.
Okay.
But that's great. So breast changes are a great indicator that your body's preparing for lactation. So really good way, and it can look all different. So if you don't have all of the same characteristics that Lily just described, any breast changes, you talk to your lactation consultant and they'll talk you through it. But any breast changes are a positive sign.
Okay.
I guess I will also ask, like, you have breastfed before. I know this about you. How long did you breastfeed your last?
I breastfed for 14 months.
Awesome. And any
Which I
issues?
shocked myself by, I just want to say. Like, I thought I would be like a 3 week and done type of person. So just my biggest lesson from the first time around is never say never, because you don't know what you don't know. So
Yeah, I think it's great to be super open in general with parenthood. I think it doesn't matter how type A you are, when you become a parent, it's really hard to stay firmly type A. And so I think that's great advice, Lily, to just be, thinking about how anything can change at any moment in terms of what your goals are. And the more flexible we are, the more in control we feel. And I think that's an important thing for our mental well-being, is to feel like we have control over our bodies, over our choices when it comes to pregnancy
yeah.
and lactation. And so knowing that it could change. And your healthcare providers should be really flexible with you on those changes, including your lactation consultant. So I'm always prepared from one visit to the next that there might be new goals, there might be new things that pop up. So during that 14 months, was there anything that came up that was a like an issue? Like what did you find was challenging about breastfeeding your first?
As I stare at my breastfeeding cart that I'm setting up that has those like disposable nursing pads, I'm triggered because I'm gonna go very TMI, just FYI, everyone. I had extreme oversupply, and I think I did that to myself. I never have worked with, this is my first time ever working with lactation consultant this minute. And I consistently wore that haka on the leaking boob, not realizing that that was actually a manual pump. It wasn't just the collector of the leaking milk. And so I would say like the biggest issue was oversupply, and I would like soak those pads and my sheets, and I hated that. And it wasn't probably until like 6 or 7 months into breastfeeding that like I started to get my rhythm. I think I was also, we'll talk about like pumping cadence, but I think I was probably pumping incorrectly or on the wrong timeline. I wish I could remember exactly. But I do remember like I would try to go to sleep around 11, and we were fortunate to have, I got a night nurse, and so I would like wake up at like 7 without pumping in the night, and then I'd
Yeah.
wake up so
Yes.
engorged.
And that's normal. And so there is a time where you can sleep that long. There is a time period when I don't recommend going that long without stimulation. And that's, again, a great case for why it's awesome to have a lactation consultant who, when you're ready for that, or if you have access to a night nurse, they can walk you through like, what is your breast stimulation schedule? But I'm really glad you brought up passive milk supply versus active milk emptying and all of those things. And so one thing we really need to think about is social media paints a picture of breast milk storage as like this sort of like superpower, like somehow
The
to be like,
fridge.
yes, like to be a full mom, you need to have ounces and ounces and you have to be able to like show everyone your supply. And I will just tell you, like, there is no reason unless you are like adopting 5 children at the same time that you need to have a fridge or deep freezer full of breast milk.
Okay.
Very few instances when we do that. So early day pumping should be really mindful, meaning we're going to do it for a few specific reasons. So in your case, again, don't know the whole thing, and I know you had to like go back a little bit, but hyperlactation can happen if a baby is breastfeeding, transferring milk out really well, and we are additionally stimulating our bodies with a pump, whether that's a more passive collector like your Haka or something like that, or a manual pump or your regular breast pump. Anything that's taking that milk out, even slightly in an active way, is stimulating supply. And so what we do is if our babies are feeding great, our body's going to regulate based on what baby needs and is taking. If we take more than that out, your body, the little workers on that supply line are going to say,
Yeah.
we need to make more. She's demanding it. We've got to make it. And so I think a lot of people sort of glorify oversupply, like it's this really cool thing. And of course, like, sure, it's better than undersupply, but it is an additional issue. Like you're mentioning, it's not something that is like you can't enjoy it as much. Babies sometimes have a really hard time dealing with your
Oh my
leg.
God, I would
When you
like
have
drown him and then also like leak through my shirts. It's not cute.
Right. It's messy, it's all the things. So really before you start pumping, think through that. And I think it's really interesting too, because hospital staff will say things to you like, you shouldn't pump until 4 to 6 weeks, which can also be misleading because in the very early days when your milk came in, Lily, do you remember, did you get engorged when your milk first came in, like first week of life?
Basketballs.
Okay. So
Like
obviously,
I wish I could show a pic. Like if it was kosher to show my boobs live on this, I would show the photo.
I love that. So I think that is a really good point because breastfeeding can be going amazing. And then your milk comes in, which is like something we want, we're anticipating, we're excited about it. And all of a sudden the latch starts to hurt. Babies whining and complaining because they can't get deeply on the breast. Think of it like an overfilled taunt balloon. All that's sticking out is your nipple. And when a baby, I'm going to use my little example breast, when a baby is only latched onto the nipple, that's a nipple feeding. That's not a breastfeeding. And so you can imagine when we can keep this tissue soft, The
Yeah.
chance of a baby latching on deeply versus at your nipple, it's so much better for you, so much more comfortable for the baby to be able to actually get milk out. And so pumping can actually be appropriate during that engorgement phase, right before a feeding, to just soften the areola. There's also a technique called reverse pressure softening that moves swelling out of your areola. If we have a chance, I'll show you how to do that. But
Okay.
those two things, so really occasional, like 1 to 2 minutes of hand, like manual pumping or using a haka style right before baby latches can be appropriate. So again, when we take any universal language like don't pump until, or you should pump to get an extra supply, we over apply that rule and then
Yeah.
we sort of mess up our breastfeeding relationship. So I'm glad that you brought that up. I think that's
But
something that,
so
yeah.
should I forget the before the feed? Like, what about, and I don't even know if this is the proper way to do things. I want to just like talk about my situation because that's
Yeah.
all I know. The baby comes. I am assuming I'm gonna have the same situation I did last time. So the milk's gonna come in, I'm gonna be engorged. I learn better by repeating what you're
Yeah.
saying. So then if I have that engorgement, I either can use a manual pump, a Haka, or the
The
pump.
reverse pressure softening. You can also use hand expression to soften that areola to deepen the latch,
So
but you're
you wouldn't
not
use your
emptying.
electric pump?
You can. I find for most people, it's just not super practical to like make sure it's all set up and ready to just like do a moment of pumping. So like I find that's where a manual pump can be amazing.
Got it. And I
Most,
didn't have a manual pump last
yeah,
time.
I was,
You told me to get one, and I did.
yes, good. Most of the time too, hospitals will often give you a manual pump if you ask for one. They
Oh,
have them in stock in a lot of hospitals because they're good for like every parent to have. So ask for one as a backup. They may have one.
I
Um,
will.
yeah, and then you'll have that as a thing that you'll have. The other thing to ask is for them to do a flange fit on you while you're at the hospital. You have access to lactation consultants. If you haven't done a prenatal visit, I really want everyone to reach out to the Lactation Network and try to do a prenatal. But if you miss it or you're early postpartum, in the hospital is a great time to ask them to check your flange size. They'll just
Just
confirm.
tell everyone what a flange is, because I didn't
Yes,
know. It reminded me of like Phoebe from Friends.
phalange.
Yeah.
Phalange. So a flange is the part of the pump. It's usually circular and it sits on your breast. And I'm like, she has one in her little basket. It looks like you're Mary Poppins
It's
pulling something out of thin air.
something.
Yes, so that is a flange. And that will sit, your nipple goes in the center and that will sit and pull. And so that the diameter of the inner hole that sucks your nipple in and out comes in different sizes. Yep. And so it's important to have your lactation consultant take a peek and tell you what the appropriate size is, because it matters for how much milk you can get out with the proper flange size, as well as comfort for you. And comfort's important, especially if you're going to be going back to work and going to be pumping, 8 to 10 times a day. You want to make sure that you're comfortable, or you're going to be exclusively pumping mom, for example. So flange size is important. So definitely that should be part of your prenatal prep.
That is amazing. I am definitely going to do that in the hospital. I didn't know that that is something that you could ask for.
Yeah,
Now,
absolutely.
okay, to go back, so the
Yeah,
milk's in, I'm doing the things before the feed to be less engorged so
yeah.
that the baby can grab not only to the nipple but to the breast. In my situation, I will have a night nurse again.
Okay.
Like that that is my gift to myself.
Yeah.
And so if I do want to prioritize sleep overnight,
Yes. So
yeah,
yeah. So in the early days, I would recommend not going more than a 4 to 5 hour stretch.
okay,
In the first 6 weeks, you're really laying the foundation for your long-term supply. So that's why in that 4 to 6 weeks, if you're overstimulating, you kind of create oversupply. If you're understimulating, you create undersupply. And so that demand, the supply demand principle, super important. And so at night, we don't want to completely go like 8 or 9 hours too
okay,
early. or our bodies are like, we're not sure what to do. Maybe she wants milk, maybe she doesn't. And so Lily, you and I can work like really closely during that time to assess like what's happening with your body when you sleep 5 hours. Nothing? Okay, maybe we can push it a little bit. So it's a very case by case, person by person. These rules do not apply to every single parent. We all lay down a different amount of prolactin receptors in our breast, which affects supply at each pregnancy. And so I can't make a universal statement like every person is allowed to go this long. It's really like biologically how our bodies respond to that. So we would start you with like a 4 to 5 hour stretch. And if you don't want to nurse at that 4 hours, I would have you pump.
With the electric. Oh,
Yes,
or
with the electric. When
okay.
we are replacing a breastfeeding, so let's say your baby was in the NICU for a few hours or a couple days, or let's say that like if a parent knows their baby is going to go to the NICU, we would then make sure that that parent pumps in the first hour of life and pretty often after that, starting right away. If we are planning to have our baby access to us, then we don't need to do that early pumping. But anytime we're replacing a breastfeeding, so the baby's not going to breast, and we want to empty our breast as if the baby was nursing, we're going to usually use an electric pump for that because it is a bit more effective and powerful than, and to be honest, really time savings. If you're using a manual pump to completely empty, it's possible, but you're going to have to spend the time on one breast and then the other. Whereas we can do dual pumping with an electric pump.
That makes complete sense. Okay, so then when I didn't formula feed, I think for the first like 12 months, and then I started to supplement. But this time, if I wanted to, how does formula feeding replace a feed? Or maybe it doesn't. You formula feed, but that has to be replaced by a pump.
Yes. So let's say you didn't have stored milk and you
Yeah.
didn't want to put baby to breast, you may then have to pump because it can affect your supply and maybe you don't mind. So people that are going to combo feed, very carefully will watch them and talk through what the risks are of pulling back stimulation early on. Because sometimes even if you want to breastfeed part-time and formula feed part-time, we still want you to exclusively feed for a short time as your supply gets established. Then we can pull back with usually pretty like ease. We can pull back. It's much harder to not establish a good supply and then try to play catch up afterwards. Always easier to reduce supply than increase it.
So that's that 4 to 6 weeks of that.
Yes,
Like,
exactly. So, so occasional supplementation in there usually isn't going to impact anything too deeply.
yeah,
But regular supplementation, what we would do is we would like start with pumping at that time, and then if you were like, my desire is to wean off of breastfeeding or pumping at 2 a.m. And then we would do like a special pullback of that, watching what your day supply looks like, watching how baby's reacting in terms of signs of cessation, that they're full, that they're happy after feeds, in order to sub that feeding. So it's, again, it's super different because everyone's journey when they combo feed looks a little different. Not everyone wants to do 50-50. It might just be like 1 or 2 times a day they want to formula feed. So it varies a lot and it just depends. If some parents have a lot of stored up milk from that initial engorgement where they're taking a tiny bit off right before baby latches, and they can use that milk at other times, or a parent can pump 1 or 2 times during their daytime hours, and that gives them enough for at least 1 night feed. So there's a lot of different combinations we can do to allow some alternate feeding methods when parent and child are ready for that.
got it. So then I guess one follow-up question to that is, let's say baby's going to go down for their first like stretch of night sleep. I
Yeah.
know whatever that means in the early days, around like 8 o'clock, 8 p.m.
Yeah.
And I'm not going to sleep until 10 p.m.
Sure.
Do I then wait up till till the baby needs to feed again, not go to bed at 10, or do I pump before bed and then that the baby gets the bottle?
Yeah. So you have a couple of options.
Okay.
One, we want to make sure that baby's latching well before we introduce the bottle. So usually we
Okay.
can introduce the bottle around 4 weeks seamlessly, between 4 and 6 weeks, without causing any disruption to breastfeeding. And some babies, case by case, if a parent is telling me I'm not going to breastfeed exclusively for 4 weeks, we work with them and we work on that.
Okay.
But the safe is to say around 4 to 6 weeks is a good time to introduce the bottle. So let's say baby goes down at 8. You have a couple options. One could be you do what some people call a dream feed, where you sort of bring baby to your breast, and if they feed effectively, awesome. You've just fed them. They're good now for another 2 to 3 hours. You both go to bed and you have that stretch of sleep. Or the method that you spoke of, where I'm just going to go ahead and pump now. I'm going to leave that bottle for your night nurse or your dad or partner to feed. And I'm going to do a stretch of sleep in the other room. And then and then 3 or maybe you do your 4 to 5 hour stretch, then you get up, and if baby's ready to feed, awesome, you feed. If not, you pump again. So you have some options there. And it's super nuanced, but it's totally possible to just like have that guidance. But you can see why like having advice from someone, it can be super helpful, because these are all
100%.
questions that, like, if you tried to Google it, isn't going to be custom to your situation. And so it just makes it a lot harder to get good guidance from sources like that.
Without asking you that question, my gut would have been get as much sleep as I want. But that what I want, of course, is sleep. What I
Yeah,
want more than sleep is to not have the oversupply that I had last.
right.
And like 4 to 5 hours, I hear that and I'm like, okay, that's not like nothing.
Nothing. Right. Yeah, exactly.
Pump
And I
and
think,
or you feed and then you go to back to bed.
yeah. And we also try to coordinate that stretch to when you fall asleep. So like what I always try is like, let's say we're like, hey, at 11 p.m., are you tired enough to do your stretch then?
Yeah.
Let's try to coordinate. So baby gets a really hearty feeding at 11 p.m. You then will get the nice oxytocin rush that will help you quiet down for the night. Baby's going to get some melatonin in those late night breastfeedings, and that helps them go right back to sleep. And so we, want to do that stretch when it makes the most sense for mom and baby, and get baby's circadian rhythm set up with yours, so that that stretch becomes pretty seamless. And usually a solid 4 to 5 hours in early postpartum feels great.
Yeah.
Like, you'd be shocked at what you
I
can
mean, I
function.
had that last night, I feel like, and
Yeah.
I
In between your trips to the bathroom and everything
I
else.
literally, yeah, that's a whole another thing. I also filmed my first pelvic floor therapy session. So
Oh,
that was
amazing.
fun.
Yeah, that's great. No, I love that.
Mhm.
So I think that's a great basis for just those early days. And understanding your risk for hyperlactation is what we call oversupply. We'll
Yeah.
just be really careful with stimulation beyond what baby is doing. But again, case by case basis, we'll see, right, what this baby does. And
Yeah.
this baby could do something very different than last baby. So we're going to follow you closely to make sure that we're meeting your needs there. What type of delivery do you think you're going to have this time?
So I have a scheduled C-section July 23rd. I pushed for 4 hours last time to end up in an emergency C-section. And I am so uncomfortable this time that I just don't want to go past 40 weeks.
Yeah,
So
I
I
think that's
scheduled
reasonable.
that C-section. However, and I'm working with Walla and they're awesome. But the plan is to attempt for a VBAC if my water breaks or if I go into natural labor
Yeah,
before the 23rd,
before you
which
do. Yeah,
my water did break naturally last time before my due date. I'm not saying that that is going to happen again, but that is
yeah,
what I know. Um, he is 98th percentile in size, so whether they let me go for the VBAC, I don't know,
yeah.
but
Usually they'll let you try to labor, and that's great. I mean, I think if you have that experience and you're able to go through any amount of labor, kind of just helps get things moving in terms of like from a hormone perspective. But if you have your scheduled cesarean, there's also the advantage of like physically you're not as exhausted, right? Like, so there are some advantages when it's a repeat cesarean to have just a very different situation than last time, where you mentally, it's a lot, you probably feel a little bit better just kind of knowing that either way you can handle the outcome. You've done it,
yeah,
C-section. If you do it vaginally, awesome. If you have another C-section, okay. So I think you're in a great mental space when it comes to your delivery. Many hospitals allow skin to skin contact after cesarean.
uh,
So that's something you certainly, if you don't already know, you can check with your hospital about that. That skin to skin contact, skin to skin is basically the next best thing to putting a baby to breast. So if you're not able to breastfeed during that recovery period, putting baby skin to skin is
Closeness.
great hormonally to just get things moving. So for any of you that are going to have what we call a surgical birth, absolutely there are things you can do. Also, some babies have trouble with what we call the transition, which is I'm coming out of a water-filled environment. I don't use my lungs, my heart valves work differently, and now I have to survive on the outside. And so for some babies, they're like, whoa, like pump the brakes. It's a little rough out here. And it takes them a few hours to transition. And those babies often do have to go to the nursery, which means you don't have access to them for those early lactation and skin to skin. And so a couple of things you can do there is they will give you the nursery can bring you the blanket they wrapped baby in to lay on your chest while you're separated from baby. And then you can do some hand expression to stimulate your colostrum flow and get things moving. Many hospitals now have these little small colostrum collectors, and they'll take that down to the baby and they can like put it on the baby's lips. And because the volume is so low, they don't necessarily need to like suck and swallow and coordinate all of that. Because usually if they're having trouble with transition, we're not going to ask them to also figure out how to feed. And so we can use that colostrum to do what we call like oral care. Colostrum is very important to get the gut ready for their first meal. So for, I don't know what your colostrum supply was like, or if you were able to hand express last time, but it's not a lot, right? Like compared to milk, you're like, okay, like I'm getting some nice big drops. I want you to think of that as like the appropriate first food for a new person that's never eaten before. Think about that too.
When I'm listening.
Oh,
Excuse me, sorry.
you're okay. So do you remember what your colostrum was like, or if you
Okay,
did?
no, I don't remember, but if I were to squish my boob now, which sometimes I do for fun,
Yeah,
stuff comes out.
awesome.
So should I be doing that? Is it too early?
So colostrum harvesting, I thought that might come up. It has really garnered a lot of interest lately. And there was a study where they really looked at the safety of colostrum harvesting. And in most cases for low risk or no risk pregnancies, it is very safe. I always have the caveat of absolutely talk to your doctor first. It's very important to talk to your doctor first. The advantage of colostrum harvesting is that we put aside some of the fresh new colostrum in case you're separated from your baby, in case you don't feel like hand expressing right away, in case your baby has like, so in the case of gestational diabetes, those babies have a higher risk to have low blood sugar. And so having colostrum on hand to use if their blood sugar goes down a little bit prevents them having to have formula or what we call glucose gel. And so it can be a great thing. It's also nice to be able to like practice hand expression in a non-pressured environment, right? Like I don't have a screaming baby in my lap that I'm like, please, can I get a drop? It's like you said, it's kind of cool. You're just like, okay, something's coming out. Great. So I think if your doctor approves and says that it's safe, go for it. I think it's a great way to just like learn how to get comfortable touching your nipples, touching your breasts, seeing what feels okay in terms of hand expression. There's like a very specific technique that we want to use, and just I'm not going to go like too deep because we have a lot to cover, but you don't yank your nipple. It's really more about pressing back
from the soft part.
Yeah, so you push back towards your chest wall and roll your fingers. So you're pressing and rolling kind of. So not to be funny, but like if you think about if you've ever seen anyone like milk a cow, they go like up and press on the udder and then gently press down. They're not at the tip of the udder yanking on it. So I think when you really think about the way that our breasts work, it's not comfortable to yank at your nipple. Also, you have no milk making materials in your nipple. All the milk making stuff is back here. So that's the same reason why we want baby latched here. Your hand should be in a similar place to where we want a baby latched. So, so that's how to think about it. But I'm glad you brought up that harvesting of colostrum.
And I heard you say, and then we can move on, but only hand express, so that I would not hook up to an electric pump.
Typically, I wouldn't advise it. It's usually not very effective at getting colostrum out because colostrum is so thick, it's low in volume. And when you use an electric pump, it's great to stimulate. So in your case, no, don't do it. We don't need to stimulate. But it's not great for expression of the actual drops of colostrum. So I don't want to knock the electric pump because in some cases, again, in a case where a parent is separated from a baby, we want the stimulation of an electric pump to really get the hormones moving. It doesn't mean it's going to effectively really get colostrum out, but it is going to stimulate the body to understand that baby's been born, isn't latching, and we want milk. So there is a very specific use case for your electric pump in the early days, but it's very specific. For actual expression of colostrum, hand expression is one of the most effective ways.
Great. Noted.
Okay. So we know that you may have a cesarean, may have a VBAC, so that's great. We have a plan in place to get you that skin to skin. Early latching is great. I want you to think of early breastfeeding as an exercise and like conditioning your baby to understand feeding, because from their moment of consciousness in the womb, they've never fed, they've never been hungry.
Yeah.
And so I think even when we use the term hunger in the early days, I'm like, not really fair. I mean, we're conditioning baby to understand their body. So any discomfort to a newborn, I'm hot, I'm cold, my mouth is dry, I'm hungry, can feel or look the same. Their cries can sound the same. And so it's hard to differentiate hunger. Now, there are cues that are biologic, that are things that happen when a baby, when their like blood sugar is reaching a point where they need more food or anything like that. And hunger cues are something that there's lots of literature on. There's lots of things you can look up about hunger cues. But essentially, a screaming, crying baby, we've missed their hunger cue. They already were expressing to us that they were ready to feed again. And so a good principle in the hospital is to feed at least, so attempt to feed at least every 2 to 3 hours, or, and this is a big or on demand. So babies sleep so much in the early days that if you have a baby that happens to be awake, even if they fed 45 minutes ago, I'm feeding them again. Because they could feed for 3 minutes. They could feed for 20 minutes. I don't know when they're going to be interested to go on again, because again, their drive to go to your breast,
they don't have it yet.
It's not like us. It's not like they're like, oh, I have a need and I know how to fix it. They don't get it. So what we're using is their reflex, which is on the roof of their mouth. We're using that reflex to make them feed. It's an innate reflex that's there that protects our survival as babies. And so what we're doing is we're using that reflex. Once we get good at stimulating that reflex, babies then start to enjoy it. But it's still less about a meal, like a steak dinner, and more about, think of it, the colostrum and early feeding like a lollipop or a popsicle. It like tastes good. It like moistens your mouth.
Yeah.
And the sucking and being close to you makes them feel comfort. Still, though, very erratic, because it's not about stomach full and emptiness. And so even though we're telling you every 2 to 3 hours, your baby's going to get hungry, not totally accurate. When you really think about the basis of how hunger forms, the basis of how our babies eat, their tummies are so small that they don't know that it's.
Is that how small they are?
Yeah, it's usually the size of like a shooter marble, or, I mean, they're just teeny tiny.
I just feel like that's another social media thing where it's.
It is.
And that puts so much pressure.
Well, and you don't know how many times I hear from patients in the hospital tell me, my baby doesn't like it. I'm like, your baby is 12 hours old. They do not have an opinion, I promise. They do not have an opinion at 12 hours. Their world has been rocked. And if they can't concentrate on sucking and breathing and swallowing, and they're fussy at your breast, it doesn't have anything to do with you. It has to do with overstimulation, being too hot, too cold, having too much space to move around. I like to use the example of, like, for anyone that's pregnant, that feeling when you feel that elbow push.
Happening this whole time.
Right. So if you think about, if every time you moved your arm, you met extreme resistance, and then one day you woke up, went to move your arm with that extreme resistance, and there was no resistance there. Woo! Right? Like, that is shocking to a baby. It takes them a few days to get used to the freedom of movement. And so I think just like allowing our babies time to process their biologic changes is so helpful, because we're putting high expectations on them. We're putting super high expectations on ourselves. And when they don't align perfectly, we're like, it's just not working. Or if someone puts a pacifier in their mouth or a bottle in their mouth, they'll go, well, look, they're taking that perfectly. Well, that's a tactile stimulation. So when we're talking about that reflex on the roof of the mouth, if I take a very perfect, long, firm pacifier or bottle nipple and push, think of it like a button. I push the button. Of course they're going to suck on it. Of course they're going to suck on it. It's easy. It's easy to suck on. So that's why we kind of avoid artificial nipples in the first few days. Typically, I use my finger to soothe the baby because it's attached to me. I'm not going to accidentally leave it in their mouth for 4 hours.
It's not the perfect shape.
It's not the perfect shape. So it's you know, we're saying babies need to be like calmed, and there's all different techniques we can use to calm a baby. But they really don't need a pacifier or formula in those early days unless there is a medical indication for those things, or it's a preference, right? Like
And what are those, like just extreme weight loss?
Yes, yes. And honestly, again, if you start working with a lactation consultant, they're going to be following your milk supply coming in really closely. They're going to be following the effectiveness of your baby's latch, how well baby's transferring milk. And so if for some reason we do get to a place, because it does happen, there are babies that burn calories faster than other babies. And those babies, the colostrum may not be enough for them, but that is an extreme rarity to the norm. And I'm glad you brought up the weight loss. So some weight loss is normal. And I think that's another huge reason why I have parents second guessing themselves is any weight loss. They're shocked by any weight loss. And I just want to mentally prepare everybody, including you, Lily, that in the first week of life, babies can lose up to 10% without that being a problem. Okay, their bodies are innately filled with extra fluids and what's something called brown fat that can be burned for energy. So weight loss is to be expected. Now, when we see it more than 10%, that's when we want to intervene in different ways. So maybe we get mom pumping, maybe we quantify what she's giving baby by letting her breastfeed first and then give pumped breast milk afterwards or a little bit of formula afterwards. But up to 10% can be totally normal, especially if your baby's peeing and pooping appropriately. So
That's what my next question was going to be.
Yes. So we want 1 wet diaper in the first 24 hours at a minimum, 1 wet. We want 2 on the second day, 3 on the third, 4 on the fourth. And then when we get to around day 5, 6, we should see somewhere around 6 to 8 wet diapers a day. And then
so many diapers.
I know, so many diapers. And then stools are going to vary. So stools at the beginning can be pretty infrequent, thick, tarry meconium stool. Meconium stool is not made from breast milk or food. Meconium stool sits in your baby's gut right now. So Lily, at your stage, your baby is going to form meconium stool in the gut to protect it as it fully develops. So when they're born and they take their first breath of air, it's going to open that tube. So if you think of the mouth down to the bum as like a tube, it's going to open that tube to air, and that meconium is going to start getting pushed out.
Wild.
Yeah. And so what you'll see is like thick tarry stool first couple of days. Then when you have more content going in, so your breast milk starts to transition or they get more colostrum, you'll start to see the consistency change. So you'll see it go from like really black, dark green, stretchy like tar to something a bit more muddy, runny, and that's a good sign. And so a lot of people think that breastfed babies have diarrhea. And my commentary there is breast milk stool is very benign smelling, not their toots. Their toots can sometimes smell like a grown person, but their actual poop has a very benign, mild smell to it. Oftentimes it's liquid with what looks like seeds on top. That is completely normal. That's just undigested milk curds that you're seeing on the top of the diaper. And the stool sinking in is fine. And we count anything more than a quarter as a stool. So sometimes you'll see like a streak in the diaper. That's usually just like a little wet toot that you have. But when we see at least a quarter worth of stool, we can count that as a stool. So when your doctor asks you how many pees, how many poops, if it's at least that quarter size, yeah, you're good. So yeah, I mean, I think all those things are really important. Additionally, did you have any anatomy concerns during your last pregnancy or breastfeeding in terms of like easier side to latch or anything?
No, but my right breast, I remember, just naturally always produced more. Like I would see that from
Yeah, so that's really common. So for anyone that exclusively pumps or ever pumps both breasts at the same time, it's very typical that one breast, we call them like like the wonky breast and the overperformer. So you have like one breast that does tend to
The
produce
dud.
more milk, yes, and one that produces less. And that can be really, really normal. There's really nothing wrong with that per se. It's something we see super commonly. Not very many women have perfectly symmetrical breasts, to be honest. And so usually you'll have one that maybe has a bit more milk making materials in it than the other. And that's why we're seeing that difference. If anyone had an extreme difference, so some people actually have something that they were born with where one breast is fully developed and the other is quite wonky, either maybe they had augmentation on that side. And so it's pretty common for us to know that the side that had to be augmented or the side that wasn't augmented but is quite smaller would result in less milk. Totally normal. We expect that. Sometimes one breast is enough, but definitely consult with your lactation consultant on that if you're not sure. The other surgeries that people ask about a lot are augmentation in general. And many parents that have augmented breast can still breastfeed. It depends on whether or not their nipple was completely removed or not. It depends on where the implant was placed. And then it also depends on how long ago it was. So when someone says to me, like, I was augmented at 18 and they're 32, I'm less worried about any sort of connection issue. With breast reduction, we do have to watch those mamas very closely. And that is because typically when we're removing tissue to make the breast smaller, we are removing breast milk making materials.
Yeah.
And so it's pretty common. So let's say if your breast is like a pizza and you have 8 slices and your surgeon took out 4, you just now have less. So it's not that you can't breastfeed. So don't assume you can't, but just assume that you'll need guidance to make sure that you can make enough.
And that wasn't me. I mean, over the years, trust me, I've definitely thought about a breast reduction, but I will share that with my best friend who is pregnant, and honestly, she should book an appointment with you.
Yeah, I would be super smart, just so that I think it just gives you the peace of mind that like, no matter what, we're going to be okay. We're going to figure out a plan.
Yeah.
And so I think that helps a lot. And then I know we only have 15 more minutes. So we talked about what we what we expect from baby in the early days. I do want to talk briefly about nipple tenderness, soreness, normal versus not normal. So did you have discomfort at all, or did you maybe get
lucky in that regard?
Okay. And that's great. I was the same way. I really lucked out until my 3rd baby, who had a really tight lip, which didn't cause any breakdown to my nipple, but I knew something was different because it felt different than my others. And so I knew something was a little different. So one thing I have learned from doing this for a super long time is I used to say, when breastfeeding is done appropriately and you have a good latch, it shouldn't be painful. And then I realized that wasn't a very inclusive statement, meaning some parents have very sensitive nipples. So discomfort is a relative term. If someone has the type of nipples that are like, I don't like my t-shirt touching me, I don't like anything brushing past my nipple, I'm extremely sensitive, then a baby tugging on their nipple may feel a little irritating. And so I find that some people do really well when they have something to fidget with while their baby latches. So when you get good at latching, if you have something sensory, whether it's like putty or like something soft, like sometimes that's a great mental distraction that can help lead to an area where you're like, you get accustomed to, you get accustomed to.
Love my squish balls.
That's right. To that discomfort. So I think there are different types of discomfort. So a pinching pain would never be something I'd consider normal. Okay. So a little bit irritable feeling, sensitivity, I can consider that in the realm of normal. Pinching pain typically is not normal, and you would want to get some advice on latch for that. So in the hospital, when your baby is first born, if you need help latching your baby, many labor nurses are trained to help you get your baby latched and at least look at the latch to make sure it's a good one. What I find is it only takes one session of bad latching to get a scab, to get sore. And in the early hour or 2 after birth, babies have what we call a quiet alert state. For many babies, their instincts are like hyper, and they haven't like hit the shock yet of like, I'm out in the world. And I find that they are very receptive to feeding oftentimes. That sucking receptor is like real sensitive. So that's good and bad in the sense that good, we can get many babies latched in that first hour or so. Bad in the sense that I joke that babies would latch to your collarbone during that time and be totally happy. So what that means is you're elated you have a new baby, you just pushed this baby or had surgery, you're so excited they want to latch, they could be latched really wrong. And you would just be like, whatever, it's
Yeah.
fine.
So just like try to get someone to look at you
Yes.
right away.
Yeah. So like
Yeah.
just say, can someone just check this latch? Because it's so hard. There's so many emotions happening,
And
so
they're
many
so
hormones.
little.
Yeah, and they're just tiny. So just knowing what's appropriate in terms of latch. And if you do a prenatal consultation, we'll really talk about like what should feel correct. What does the mouth look like? I have some good videos that I show, and all of those things can really help you kind of like focus in when it's time to focus in. So do we want to take a moment to see if there's any questions? And then I'll see.
Somebody said that they're being triggered by the pads. It all
Yeah,
feels
I
too
saw
real for
that
me.
at
I
the
started
beginning.
leaking during second trimester and had to use them from pregnancy all the way until when I stopped breastfeeding. That is so relatable.
Yeah, it's crazy. You're like, Lily knows I make this joke about how lactation is the only time in your life that you can have a swollen body part that's leaking fluid and not have standard medical care. And that's a really real thing. It's funny how something that is considered like normal, but that like biologically really changes our function, right? Isn't considered like a medical event. So
Ridiculous.
I just
And that's my favorite thing that you say. And then also we have a question coming in which we'll get to, but
yeah.
my first OB and the reason I switched told me I didn't need PT therapy after a C-section. And like, I was just like, what? You go into knee surgery and you have PT after. You go into shoulder surgery, you have PT after. Like, I
And
don't
your
know what
abdominal
that is.
muscles in cesarean, like I've attended many cesareans, your abdominal muscles are displaced. So like you would absolutely from the pregnancy want some PT, and then also body mechanics wise. So whether you have a vaginal delivery or a cesarean, there's body mechanic musculoskeletal changes that are taking place because of
Yeah.
hormones, your pelvic shape changes typically after a baby, whether you have a vaginal delivery or not. So yeah, I mean, I always say I love a physician that's humble enough to say they don't know everything and,
That's an
be
expert.
ready to, yeah, to
100%.
advise.
Okay, the question that came in was curious what your thoughts on body work, chiropractor, etc. for babies. I've heard it can help with feeding when it comes to favoring one side.
So I think what you're probably referring to, there's a couple of reasons why babies prefer one side or that it's comfortable on one side but not the other for the parent. And so there's twofold there. One is the wonky breast. We've talked about that. So some babies do prefer a breast that has like either a larger, more palatable nipple that like really reaches that sucking receptor well. So we really will work with them on the side that has different anatomy if we need to, and use tools if we need to. And then also, sometimes babies, again, thinking about how crunched they are in the womb, not sure how they're delivered, they can get a bit of like shortening muscles on one side. They can have a little asymmetry in their oral function. And so, yes, you can work with, there's a variety of professionals, whether it's body work like cranial sacral therapy, which is kind of like a fancy sort of specialized massage, if you think of it that way, that helps like align everything, loosen anything that's tight or not working well. I will say some pediatricians don't love these other forms of care. So definitely talk to your pediatrician. I think it's good to educate yourself too, because sometimes you're not going to agree, right? Like, and there's going to be that balance between your physician and what you decide is appropriate. Kind of to your point, Lily, about PT, right? So yeah, I mean, I think really thinking through, it's not something I would necessarily suggest that you have to do for every baby, but a lot of times as a lactation consultant, I'll do an assessment of baby's symmetry. So I'll look at like, do they easily turn their head to both sides? Do they easily, like when they're crying, does their tongue look symmetrical? Or is it like lifted funny on one side? And then I look at symptoms. So if you're having pain on one side, then I go, I wonder if something's going on with symmetry. And so we can also do referrals to like speech therapists, which a lot of people don't think about, but are super effective in treating oral motor dysfunctions.
Cool. Two more questions, Leah. So this has been really helpful. Thank you. I thought the concept of reflux and tactile sensation versus baby really knowing they're full or hungry was really interesting. I agree with that. Do you have any recommendations for bottles or passy brand shapes that you think are best once those are introduced around 4 to 6 weeks that support continued breastfeeding? Or if the latch and supply are really secure at that point, does it matter as much?
So that's great. What a comprehensive question.
Yeah.
So I would say typically it doesn't matter as much. When I really get into like preferences on pacifiers and nipples for bottles, it's around like a baby that's refusing, like bottle refusal, or a baby that does have like a weak oral motor function and we're trying to like facilitate training. We call it like suck training. So in your normal, right, like in your typical course, if everything's going really well with supply, latch, emptying of your breast, typically babies are very not picky about going back and forth from the breast to the bottle. There are techniques. There's a technique called paced bottle feeding that it's more like how you use the bottle that's more important than which bottle it is necessarily. I am a big fan of slower flow nipples though in general for babies. So don't always go with like the guidance of the age versus the bottle speed. Start with the slowest speed typically is good.
Yeah, I
And
felt
then
like, oh, sorry.
Oh, I was going to say, and then for pacifiers, unpopular opinion, I really, really do not like that green pacifier that the hospital usually gives. It's shaped exactly like a bottle nipple. It provides so much tactile stimulation to your baby that they'll be like, breast schmeshed. I don't want it. I want that green passy. They don't understand that contact between your soft, pliable breast tissue and the comfort. They've just now established comfort with that passy. So even at the 4 to 6 week mark, that's just not my favorite. So I prefer for dentition something that's orthodontic, so that it's not going to push a lot of pressure on their back gum, creating like that splayed teeth that you'll see in some children that suck their thumb or use a passy for an extended period of time. So I just prefer pacifiers that are considered orthodontic in general. And it'll vary. Some babies take different ones. And there are a few that claim that they are special. I always say be wary of anything that says it's just like the breast. Nothing is really just like the breast. But there are some that facilitate like good oral motor function. So that's really, those are the claims I like to kind of look at more.
Perfect. Another question. I have a question about my older baby, 3 months. We've done really well with feeding up to this point. I'm noticing that his feeding time has gone down about 5 minutes per side, and he will replace my nipple with his own thumb. I'm thinking he's satiated and he isn't fussy, but just wondering about what happens as baby transition from true newborns to infants.
Yeah, I mean, this is magical, right? Like this is actually the good stuff right here. When all of a sudden a baby that was taking 45 minutes or 30 minutes to finish a feed becomes super efficient. So
Yeah.
your letdown's happening faster because you're more confident as a parent. You're not as stressed when you're sitting down to nurse. Baby's mouth is bigger, their muscles, their fat pads, those little lovely cheeks that we love so much. The fat pads in a baby's cheek help close the oral cavity and create suction that's more efficient. So babies can feed really quick. So if you have good weight gain, no change in pees and poops, and he's just efficient now, enjoy it.
Good for you. Leah, every time we talk, I learn so much, especially this time. You are such a good wisdom sharer, is how I would say it.
Well,
And
yeah.
Yeah,
I was gonna say there were a couple of things I just want to say that we didn't cover.
yeah, please.
I want people to know that we do cover in a prenatal. One of those is oftentimes I invite the partner. I
Okay.
like to get information from the partner about what they're worried about around feeding. Nobody asks them. Typically, nobody's asking the partner what they're worried about.
Yeah.
And so we address then any like feelings of like, I'm going to be left out if I'm not helping with feedings or, so we deal with that ahead of time so that at like 3 a.m. or when baby's having a hard time latching, we're not seeing that sort of like partner to partner strife because it wasn't discussed or wasn't talked about. So partner is a big part of this piece of it. And then just know that each prenatal one-on-one is completely custom to your health history, your experience, what you're worried about, your type of pump, your back to work plan. And so all of those things are really in place to get you ready. And then the next visit we like to have, Lily, is going to be the first week of life. Typically, when you get home from the hospital, is a great time to reconnect. But I'm always available to my patients via text or email as well in between visits. And so just know that too, like you have a line of communication to your provider throughout your breastfeeding journey, starting prenatally.
Love it. And you're the best. And I have you on Slack. So I even am,
That's right.
yeah. Well, thank you everyone for coming. We will share the recording with people who RSVP'd but couldn't make it. And we can continue the conversation live in the Augie app. And we definitely will also follow up with more information on how you can reach Leah and get in touch with the Lactation Network, which if you have insurance, right,
Yep.
Leah? Not all insurance, but most
Yeah.
insurances.
Yes. Most insurances,
Lactate.
you can get a free visit and you can have continued free visits throughout your journey.
This
So
was wonderful. Thank you so, so much, and we'll talk soon.
wonderful. Have a good day.
Bye.